CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Good afternoon, everyone. Our first WIP of this academic year. My name is Karen Humphreys. I'm a CHÉOS scientist, and I'm an epidemiologist here at the Center for Health Evaluation and Outcome Sciences. So welcome to our first session, which is a hybrid session, and actually all of our sessions going forward will also be hybrid sessions. For those of you that are online, once our guest speaker has finished, please feel free to either raise your hand and you can ask the questions, or you can use the chat feature as well. So before I welcome our speaker, I just want to welcome all of you. And also we have two special guests joining us from Italy. So buonasera to our two guests from Italy. It is indeed my pleasure to introduce Dr. Barcella. I'm delighted that he's been able to join us here in Vancouver. He did his medical degree in Italy in 2013, and then he went to Denmark, where he has been since 2014. While in Denmark, he also completed a PhD, and he's now doing a fellowship just about finishing in cardiology. Dr. Barcella's interest is very much in cardiac arrest, and he's going to be talking to you today about some very interesting work that he has done with mental illness or psychiatric disorders. So with that, I'll turn it to Dr. Barcella.
Yeah, thank you very much. So my name is Carlo Barcella, and I want, first of all, thank for the invitation and the opportunity to present my work here. That is about out-of-hospital cardiac arrest in patients with psychiatric disorders. Okay, so these are my disclosures. These are the non-profit private funds that are supporting me here economically in Vancouver. Yeah, let's begin. So during my presentation, I will refer to out-of-hospital cardiac arrest with the abbreviation OHCA. And as you can see in the picture in the right corner, out-of-hospital cardiac arrest is a cessation of cardiac mechanical activity occurring outside the hospital. And it can come suddenly, or it can be anticipated by symptoms like dyspnea or chest discomfort. These pictures shows the main cause of out-of-hospital cardiac arrest. The red slices are the cardiac cause of arrest that account for about 50% of OHCAs, and the green slices the non-cardiac cause of out-of-hospital cardiac arrest. As you can see, around 1/3 of the causes are due to coronary artery disease. And there is also 13% due to an occult overdose. Let's see some numbers. In British Columbia, there are around 5,000–6,000 out-of-hospital cardiac arrest each year. And if you take the whole Canada, the number is around 35,000. If you go to Europe, to Denmark, where I'm from, there are around 5,000 OHCA every year. In the United States, 350,000. But it doesn't really matter what OHCA occurs, because at least in the Western countries, the survival is very low, around 10–15% at hospital discharge. Some other numbers. Worldwide, there are 3.8 million OHCA a year. And this accounts for almost more than 50% of all cardiovascular deaths and 15–20% of all deaths worldwide. So we are dealing with a very severe disease event. That's why both the American and European guidelines have developed the chain of survival, which is composed by 4 links, 4 actions that have to be done as soon as possible when an out-of-hospital cardiac arrest occurs to maximize the chances of survival. And the 4 links are, the first one is the early recognition of out-of-hospital cardiac arrest and call for help. Then the second one is the prompt initiation of CPR. The third is the prompt use of defibrillator. And then the fourth one, of course, after the circulation has been restored inside the hospital, and it's the post-resuscitation care. Just to let you know how important these 4 links are. For example, if we start immediately CPR, we can quadruple the chances of survival. If we do a prompt defibrillation within 3 to 5 minutes, the survival chances are increased to 50–70%. And we can see the number here is much higher than the 10–15% that we have on average. So we have a lot to do to ameliorate the survival following out-of-hospital cardiac arrest. Usually, when we speak about pre-hospital, out-of-hospital cardiac arrest characteristics, we divide in favorable and unfavorable. For example, having an OHCA in a public location, or having a witness OHCA, or receiving bystander CPR are, of course, some favorable characteristics compared to the opposite ones. And also the presenting cardiac rhythm is very important for survival. When the rhythm is shockable, which means that when we can use the defibrillator and shock the patient, the survival rates are quite high, around 40%. When the rhythm is not shockable, much lower, 5–8%. Yeah, and now we take a trip to Denmark to see what happened there during the last 20 years in terms of out-of-hospital cardiac arrest. In the beginning of 2000, we had in Denmark only 20% of patients suffering from out-of-hospital cardiac arrest receiving bystander CPR. And the survival rate was quite low, less than 4%. So that's why during the last 20 years, great efforts have been made to improve that number. For example, since 2005 and 2006, it has been mandatory to to attend some resuscitation course at elementary school and when you get your driving license. And since 2009, 2010, they have the dispatch centers and the emergency medical services have been strengthened by the introduction of healthcare professionals. And all these efforts have brought to some improvements. For example, the number of patients receiving bystander CPR in Denmark has increased from less than 20% to 80%. And similarly, the number of patients receiving bystander defibrillation has increased from less than 5% to 20%. And this is due also to the fact that the number of available AED stays for automated external defibrillators has increased a lot in Denmark during the last 15 years. We have now around 20,000 defibrillators outside the hospital in Denmark. And of course, all these ameliorations have brought also to an improvement in the number of patients surviving out-of-hospital cardiac arrest. This is the red continual line show the number of patients surviving at least 30 days after an OHCA, and it has increased from less than 4% to 14% between 2001 and 2020. What about in British Columbia? We have experienced also here an increase in the number of patients receiving bystander CPR from around 35% in 2006 to around 50% in 2015. And there's been also an increase in the number of patients surviving at discharge. Almost, the number of patients has almost doubled between 2006 and 15, from 8.6% to 16%. And then we have the last, until now we have spoken about the first 3 links of the chain of survival, and then the fourth one is the post-resuscitation care. So what happened during in the hospital? This is also an important link, and the in-hospital management aims to find the cause of OHCA, treat it, and to support the vital organs. And during the last 10–15 years, there have been also an improvement in the number of patients in the in-hospital management of OHCA. As I told you before, almost 1/3 of patients suffering from OHCA have underlying coronary artery disease. So coronary angiography is quite important to to find out whether or not these patients have coronary artery disease. And in this study from the US, they show that the number of patients receiving coronary angiography after OHCA has increased from 27 to 44% between 2012. So during the last 15-20 years, we have experienced improvement in both pre-hospital and in-hospital treatment of out-of-hospital cardiac arrest. The other side, we have patients with psychiatric disorders. Mental disorders have a global prevalence of about 10-15%. And patients with psychiatric disorders have 50% higher risk of cardiovascular morbidity compared to the background population, 85% higher risk of cardiovascular mortality, and they have 10 to 20 years shorter life expectancy compared to the background population. And different mechanisms can explain the association between psychiatric disorders and cardiovascular disease. For example, the use of drugs and alcohol, an unhealthy lifestyle, the use of psychotropic drugs, especially antipsychotics with the metabolic side effects, a high burden of extracardiac comorbidities, and also public stigmatization. Different studies have explored the association between psychiatric disorders and OHCA. For example, in this study from Denmark, we found that both bipolar disorder and schizophrenia are associated with high risk of OHCA, 3-4 times higher than background population. In this older study from the US, they found 1.52-fold increased risk of OHCA associated with depression, again, compared to the background population. In this meta-analysis from the Netherlands, they found 2-fold increase associated with anxiety. And in this other study from the United States, the use of antipsychotics was also associated with higher risk of OHCA. So there is a strong association between psychiatric disorders and out-of-hospital cardiac arrest, and it's not only for more severe disease like bipolar disorder, schizophrenia, but also for less severe disease as, for example, anxiety. So the aim of my PhD back in Denmark was to compare the treatment in hospital, pre-hospital and in-hospital treatment of patients with psychiatric disorders compared to non-psychiatric patients, and to see whether or not the improvements that we have seen in the background population also apply to patients with psychiatric disorders. The first study focused on the pre-hospital management, so the first 3 links of the chain of survival, and the second study focused on the 4th link of the chain, so on in-hospital management. I used the Danish cardiac arrest registry, which is an ongoing cardiac arrest registry collecting all the cardiac arrest, out-of-hospital cardiac arrest occurring in Denmark, where an ambulance has been summoned and where CPR has been attempted either by bystander or by emergency medical service personnel. And using the CPR number, the unique and personal civil registration number, we were able to link patients with cardiac arrest from a Danish cardiac arrest registry to the other Danish nationwide registries to collect information about previous hospitalizations, the ongoing pharmacotherapy, and vital status. So what we found? This is the first study focusing on pre-hospital management between 2001 and 2015, and we all included patients with out-of-hospital cardiac arrest with presumed cardiac cause of arrest. Remember the red slices of the cake that we saw in the beginning, just to have a more homogeneous population. And we found that patients with psychiatric disorders had 25% lower probability of witness OHCA, 23% lower probability of receiving bystander CPR, 63% lower probability of having a shockable rhythm, which is the good one, the good rhythm. 50% lower probability of receiving bystander defibrillation, and 34% lower probability of return of spontaneous circulation upon hospital arrival. And of course, all these unfavorable pre-hospital characteristics lead to lower survival. So patients with any psychiatric disorder have 60% lower probability of surviving at least 30 days after out of hospital cardiac arrest compared to the background population, compared to patients without psychiatric disorders. And these results apply to all the subgroups of psychiatric disorders, with especially low estimates for schizophrenia. This figure is also very interesting. On the x-axis, we have the calendar year, and on the y-axis, we have the proportion of patients surviving at least 30 days after OHCA. The green line is patients without psychiatric disorders. The red line is patients with psychiatric disorders. And we can see that patients without psychiatric disorders survive. The survival of these patients increased steeply during the study period, while the survival of patients with psychiatric disorder stagnated around 5–6% after 2006. So the improvements in survival that we have seen for the background population doesn't apply to patients with psychiatric disorders. So we move further to the second study, where we'll focus on the in-hospital management. Again, between 2001 and 2015, and again, we all included patients with OHCA of presumed cardiac cause of arrest to have a more homogeneous population. And we found that patients with psychiatric disorders have, compared to patients without psychiatric disorder, 50% lower probability of receiving a coronary angiography. But when a coronary angiography was done, they had the same probability of receiving a coronary vascularization. So if we make the cause of arrest were probably the same. 33% lower probability of receiving an ICD. And we found that they have 35% lower probability of surviving both at 30 days and also 1 year after OHCA. In the overall population, but also in the subgroup of patients receiving the same in-hospital management. So it didn't really matter if they received the coronary angiography. They died more often compared to the background population. So now we come back to Vancouver. So the aim of my project here is to reproduce the two studies that I did with the Danish data using the Canadian data. And again, we will focus in one study on the pre-hospital management of patients with psychiatric disorders compared to patients without psychiatric disorders. And the second study, we will focus on the in-hospital treatment. And this represents a unique opportunity because we have two countries from two different continents which share both some similarities, but as we can see, we will see after also some important differences. We start with the similarities. We have two countries with similar population. Both countries have a publicly funded healthcare service. The two countries have also similar age distribution with 65% of the population between 15 and 64 years of age. Similar settlement pattern with almost 90% of the population living in urban areas, both in Denmark and British Columbia. And similar prevalence of mental disorders, 17% in British Columbia, 14–20 in Denmark. But there are, of course, some differences. First of all, the dimension of the two countries. Denmark is pretty tiny compared to British Columbia. And, we know that larger distances make the time to hospital arrival broader. So it could be a cause of different results between the two countries. different population ethnicities. In Denmark, only 5-6% of the population is non-Caucasian. The population ethnicity in British Columbia is more diversified. And then interesting, the number of physician population ratio, so the number of doctors for 1,000 inhabitants is lower in British Columbia, 2.3 versus 4.25 in Denmark. So almost 2 doctors less in British Columbia every 1,000 patients. And of course, it could be it could influence our results. Some other differences. The prevalence of substance use disorders is different. We have more people using drugs here in BC. And I expect also that the type of drugs abused are different between the 2 countries. In Denmark, primarily is alcohol, maybe here probably cannabis or something else. And also the number of homeless people in British Columbia is 9,000, in Denmark is 6,500. And of course, there are also some similarities and differences in the pre-hospital OHCA characteristics between the 2 countries. I'm going to present some data from 2016. The number of OHCAs treated per year by EMS were almost the same, around 3,000. But OHCAs, people experiencing OHCA in Denmark at higher likelihood of being witnessed, 50% versus 40%, and also high probability of receiving bystander CPR than here in British Columbia. The number of patients presenting with shockable rhythm was almost the same, 50% in British Columbia, 17.7 in Denmark. But we have quite different EMS response time. The EMS response time is the time from when the emergency medical service received the call to when the ambulance arrived at the OHCA scene. And it could be, for example, I mean, it's longer in British Columbia, for example, could be because of of longer distances here. Yeah, here in British Columbia, we use the British Columbia Cardiac Arrest Registry, which collects non-traumatic OHCAs since 2009, and it covers 4 metropolitan regions: Greater Victoria and Nanaimo, Greater Vancouver, the Fraser Valley, and Kelowna Kamloops, and it covers almost 75% of the British Columbia's population. And as I did in Denmark, using this personal registration number, we can link the patients in the cardiac arrest registry with other databases. For example, the consolidation file, which holds information about basic demographic information about our patients with OHCA. The discharge after database, which holds information about acute care hospitalization. The vital statistics, holding information about the vital status. The medical services plan, which tracks physician services, and PharmaNet, from where we can retrieve information about dispensed medication. And it's also possible to link the cardiac arrest registry with Cardiac Services BC, which is a clinical registry holding information about all cardiac procedures here in British Columbia. So just the number of patients in the British Columbia Cardiac Arrest Registry between 2009 and 2016, we have more than 23,000 OHCAs. We should exclude almost 5,000 patients because we were not able to link them to the other databases, the external database. We exclude other 7,000 patients because they were not treated by EMS. So these OHCAs were probably patients already declared dead when the ambulance arrived at the OHCA scene. And then we excluded patients, pediatric patients, and almost 700 patients because of discrepancy between the information in the cardiac arrest registry and in the other registry, leaving us with a number of adult OHCA around more than 10,000. And yeah, to identify patients with psychiatric disorders in the British Columbia cohort, so we will use both the psychiatric diagnosis and the use of psychotropic drugs. For diagnosis, we will go 3 years back, and we will receive information from the discharge abstract database and medical services plan. And for prescription for psychotropic drugs, we will go 90 days back, prior to the date of cardiac arrest, and we'll retrieve information about antidepressants, antipsychotics, and lithium. And as I did in Denmark, we'll not just compare patients with psychiatric disorder versus patients without psychiatric disorders, but we will try to be more granular and see whether or not there are differences amongst the patients with psychiatric disorders. We'll try to identify patients with schizophrenia, bipolar disorder, depression, substance abuse disorders, other psychiatric diagnoses, and then a group of patients without hospital diagnosis, but receiving treatment for psychiatric condition identified via PharmaNet. Yeah, and the outcomes of the first study will be primarily pre-hospital OHCA characteristics, so location of arrest if they differ in patients with psychiatric disorder versus patients without, witness status, bystander CPR, and of course survival outcomes. And we'll try to do also some temporal trends to see whether or not there are differences in the temporal pattern of these two groups. And in the second study, we will focus on the in-hospital treatment. So we'll look whether or not there are differences in the number of coronary angiography performed in the two groups, the number of coronary vascularization, ECD implantation, and of course, see whether or not these influence the survival. Yeah, I hope to come with the results soon. And yeah, last I want to thank you, my supervisors, Karen and Chris, and then all my colleagues and Sean for the opportunity to present. Yeah, thank you.